Hello, everyone, and welcome to today's webinar in the Public Health Webinar Series on Blood Disorders. This webinar is presented by the Division of Blood Disorders and Public Health Genomics at the U.S. Centers for Disease Control and Prevention, also known as the CDC. I'm Dr. Jean Boudreau, and I'm delighted to serve as today's moderator. I'm currently the Director of the Comprehensive Thalassemia Treatment Center at Children's Healthcare of Atlanta. I'm delighted to join you today to moderate this webinar on thalassemia. I'm joined today by Dr. Alexis Thompson, who is the Chief of the Division of Hematology and the Elias Schwartz Endowed Chair of Hematology at Children's Hospital of Philadelphia. Before we begin, I'd like to go over a few points for joining the webinar. Today's webinar will last approximately 1 hour, and please note that this webinar is being recorded. All audio will be muted. At the end of the presentation, there will be time for questions. To submit a written question, please use the questions area of your toolbar. We will respond to as many questions as time allows. We will begin with 2 brief audience polls. First, we are interested in knowing more about you. Please select your response to the poll question now. Which of the following briefly describes you, or best describes you? Are you a healthcare provider? Are you a public, are you a public health professional, epidemiology researcher and educator? Are you a person with thalassemia or a family member? Are you a community-based organization or an industry partner? All right, I want to thank everyone for the prompt responses. It looks like the majority of people on this are healthcare providers, either physicians, nurses, PAs, nurse practitioners, or pharmacists, with the second largest group being public health professionals. And we do have a few people who either have thalassemia or are family members of thalassemia patients. Next question. Which region of the world are you from? Please select one, either North America, South America, Europe, Asia or Africa, Australia or New Zealand. If your area is not listed here, pick the closest, please. All right, it looks like about 3/4 of our participants are from North America, with a significant group of people who are from Asia or Africa or Europe. Happy to have them aboard. So we will next move on. Thank you all for participating in these polls. It's very helpful to learn more about our audience, and so let's move on to the presentation. Dr. Thompson, welcome, and let's begin.
Dr. Boudreau, always good to see you, and thanks so much for the kind invitation, and from the CDC and the Anemia Foundation for this opportunity. I'm definitely not going to take up the whole hour because I'd like to leave plenty of time for questions, but I'm going to cover a thalassemia overview really with this conversation geared toward a general pediatrician. And these are my disclosures. I'm just going to do this and that. If someone can please go to the next slide, please. Great. So these are my disclosures. And what I'm going to do is I'm going to cover emerging epidemiology. It is remarkable that it has really changed in North America. Talk about advances in disease management. There are a few things that are new. Some novel therapies, and then curative approaches. I think that actually is something that there's quite a bit of buzz about. And so we'll begin at the beginning. And so just for frame of reference, what are thalassemias? Well, thalassemia is not one condition. It's actually a collection of inherited blood disorders, but by and large, they're caused by mutations in the human globin genes, and that those mutations result in the inability of the body to produce sufficient amounts of globin. By and large, thalassemias are inherited in an autosomal dominant, an autosomal recessive fashion, although there is a rare autosomal dominant form. And just for frame of reference, remember from medical school that globins are this key component of hemoglobin. And hemoglobin is that substance inside of our red blood cells that's important for carrying oxygen. And just in terms of nomenclature, when we talk about beta thalassemia is due to reduced or absent production of beta globin, which means it's a mutation in the beta globin gene. Alpha thalassemia, reduced or absent production of alpha thalassemia due to a abnormality in one of the alpha globin genes. These defective production causes anemia, and it's both ineffective erythropoiesis as well as hemolysis. The more severe form, which we're going to be spending most of the time today talking about, requires lifelong transfusions for survival. If untreated, and we certainly know this from the developing world, it leads to poor growth, organ damage, and early death. The global distribution of hemoglobin disorders is really fascinating because no matter where you're from today, you're likely to see hemoglobin disorders. Hemoglobin disorders originated across the southern Mediterranean, Africa, and into the Middle East, into Southeast Asia. But with migration, really, it's now our global conditions. And whenever I'm talking to an audience, just looking out over the audience, about 5% of the world's population are carriers. And so it is highly likely that anytime I'm talking, that there's someone in the audience who may or may not know that they are carriers. There are two hemoglobin disorders that really are the primary focus of our work, and that is thalassemia, and then another one that I might be more familiar to, called sickle cell disease. Thalassemia is relatively rare in the United States. 10,000 is pretty generous in terms of a likely upper limit, but there are about 60,000 births per year worldwide for thalassemia. Compare that to sickle cell, where there are about 300,000 births worldwide, and about 100,000 in the United States. Over time, the demographics have changed. This used to be really strictly a pediatric condition. So in the 1970s, the median age of survival was only age 11. By the middle of the 1980s, we had begun doing chronic transfusions, and we saw that we were able to get survival to improve. By the 1990s, we were refining transfusions and also added iron chelation, which I'll talk a bit about. And so we saw yet again a bump in the survival. What you'll also notice is that as we look at these different curves, you'll see that the curve gets wider. And so while there still continue to be people who are relatively young, less than age 5 with thalassemia, we're seeing more people that you can see in the dark squares that are now living into middle age or older. And on the right side of your screen, what you're seeing is data that was published recently from the CDC. And that looks at patients in the current era. And you see that the average age is currently continuing to rise. So it's about age 20. But again, with people who are living from birth all the way into older age now. The other thing that has changed about the demographics of thalassemia is where they originate. So certainly well into the 1990s, the most common group of individuals in the United States with thalassemia were of Mediterranean ancestry. Over time, we have seen a shift so that most younger patients are now from Asia. Let's talk about how you diagnose thalassemia, because I think that that's so important. There are a number of methods, and I'll walk through how one could utilize each one of those. I'm going to start with something called high performance liquid chromatography, or HPLC. Hemoglobin electrophoresis, which I suspect or I hope is a test that you have more readily available in your local facility. DNA analysis is very important for thalassemia, but then also so is a CBC. Now, a number of my comments are going to focus on beta thalassemia just based on its frequency, but certainly I am more than happy to take questions about alpha thalassemia, or I'll intersperse some things that are really important. But this is sort of a mock-up of an example of what an HPLC tracing might look like. And this actually is a lysate of cells that are actually loaded onto a device, and then we look at it over time and look at the absorbance of light at a certain wavelength. And the one thing that's noteworthy is to show that hemoglobin F runs or comes off the column at a distinct time compared to, say, hemoglobin A, which is adult hemoglobin, which is separate from hemoglobin E, which I'll come back to, and S, which is sickle, and C, which could be a subform of sickle cell disease. And so it allows us to differentiate between normal and common abnormal globin variants. This method happens to be used at many state newborn screening programs because it's very amenable to high throughput. But certainly most of us have access to hemoglobin electrophoresis, and it also allows us to separate most normal and common abnormal globin variants. You do have to do it at 2 different pHs, so acidic as well as a low, higher alkaline pH. It cannot can't quantify hemoglobin A2. Not super important, but yet you can get that quantified often in your laboratory. Having said that, today we probably would not rely solely upon hemoglobin electrophoresis for confirmation, and instead would recommend send out labs using DNA-based testing to actually confirm the exact genotype of individuals with a thalassemia, bearing in mind that this may require prior authorization, but something we can definitely talk about. It's also important to recognize that newborn testing, or testing in the first, say, 3 months of life, is going to give you different results than if you were to do testing anytime later in life. So if we were talking about HPLC or even a hemoglobin electrophoresis, children who likely have homozygous beta thalassemia or beta thalassemia major would only have hemoglobin F present, and that would be highly uncommon even for a healthy full-term baby. There's also another form of thalassemia called E-thalassemia, and I'll talk a little bit about that one more on the next slide. The pattern there would be F and E being present, but no normal adult hemoglobin or hemoglobin A. When you think about the post-neonatal testing, so say this is a child who's from an immigrant family or for whatever reason is just coming to your practice for the very first time, a CBC should give you some clues, because these by and large are people who have microcytic anemias of varying degrees of severity. They may also have an increased total RBC count. And on your local hemoglobin electrophoresis, you may find that there's little or no hemoglobin A, but there is predominantly hemoglobin F, maybe an increased hemoglobin A2. Those are the things that should clue you in that they do need further analysis, and that's where the DNA testing comes into play. Now, but the bottom line is that the criteria for thalassemia or your level of suspicion should be different once you get beyond the infancy. Hemoglobin E may be a new type of hemoglobin to some of you, but actually it is relatively common in some populations. So 30 to 45% of people from some Southeast Asian countries, so places like Vietnam, Laos, Thailand, have high gene frequencies of hemoglobin E. This is caused by an amino acid substitution, a point mutation, the beta globin gene, that actually results in abnormal splicing of mRNA. And so there's just an unstable hemoglobin that's produced, and so there are reduced amounts of hemoglobin that are produced. It is certainly possible to inherit 2 copies of hemoglobin E. Not too bad a disease. It causes microcytosis with mild anemia, but there is some risk of hemolysis with illnesses. The real important point is that you can inherit hemoglobin E from one parent and beta thalassemia from the other parent. So an E allele and a beta thalassemia allele, and that combination can be as severe as homozygous beta thalassemia, causing a phenotype of beta thalassemia major. And so E alone should not necessarily make you feel confident that this is not a thalassemia. It very well could be. We're also in the process of kind of changing our nomenclature. So for instance, I just mentioned beta thalassemia major. That certainly is something you will still hear. Yet when we talk about beta thalassemia major, that was often someone who was co-inherited 2 thalassemia genes that would result in almost no globin being produced. Their same phenotype could also be someone who has hemoglobin E beta thalassemia. It could also be some of the alpha thalassemia variants, like alpha thalassemia major, which is a very rare but horrifically serious disease, or hemoglobin H constant spring. Instead, today, we actually have all of those together under the umbrella of transfusion-dependent thalassemia, or TDT. They matter because these folks are going to require lifelong transfusions in order to survive. Now, there are varying degrees of less than full lifelong transfusions or transfusion dependence. There are some people who need transfusions when they are ill or when they have things like pregnancies or infections or require surgery. There are some that that would benefit from transfusions because they're having poor growth or developmental delays. But then I would argue that there are many people who would have what we used to call thalassemia intermedia, or a mild form of hemoglobin E beta thalassemia, or more mild hemoglobin H, which is a form of alpha thalassemia. And those we would simply call non-transfusion dependent thalassemia. So I've talked about TDT and NTDT. Bear in mind that neither one of these are the carrier state. The carrier state used to be called, and still is called, beta thalassemia trait or beta thalassemia minor. It's really important in terms of counseling your families to be sure which one of these you're talking about, because certainly those who have trait or who have thal minor, their issues are largely related to their risk for future pregnancies or for the individual and their lifetime in the future. But these other two conditions are ones that really require acute management. What is management of thalassemia? Well, chronic transfusions I've already alluded to. Iron chelation will be essential because there will absolutely be iron loading if you are giving someone red blood cells. Splenectomy is still a useful thing to consider, although it is being done less often in thalassemia. I am going to touch on stem cell transplant as well as gene therapy. When we think about what I do and what most of us who take care of thalassemia patients do, you know, we have to sort of look at the sum total impact of thalassemia on the entire body. And there are very few organs in the body that are not impacted by what otherwise would be a single monogenic disorder in red blood cells. It can cause problems that result in facial deformities, an enlarged spleen, pathologic fractures, premature closure of growth plates, and short stature. It can cause deposition of iron in a variety of different locations that cause endocrine problems, which I'm going to touch on. Can also affect the bone as well. And so when I'm thinking about thalassemia care, I'm trying to balance making sure that I'm giving enough transfusions to actually avoid some of the complications that are in red on your slide. But when I'm transfusing, I want to be sure that I'm doing chelation effectively, because otherwise I will have the complications that are written in black on this slide, because those are by and large due to iron. We really have to do both, and balancing those is really a significant portion of what hematologists are doing on a daily basis. Let's talk about transfusion initiation. There are definitely some considerations. First and foremost, we really often wait till we see some evidence of anemia. Now, for some of the beta thalassemia major patients, or TDT, it becomes obvious before the patient is 6 months of age. But sometimes it's out to about a year, like for instance with H. constant spring. Could be later for some of the more mild forms like E. thalassemia. But once if you've done early diagnosis, you're monitoring the patient and you're either starting the transfusions if you have that capability, or you are referring them to a thalassemia treatment center so that they can begin transfusions, and anticipating that in your conversations with parents. Another reason is growth issues. This is particularly important when someone's anemia seems mild, and for instance, you're not transfusing them, but that they are now 2-, 3-, and 4-year-olds, and that their growth is starting to drop off. Really a good time to consider transfusing them, because many times you will see their growth trajectory pick back up. Bony changes. Now, bony changes in and of themselves are not fatal and they're not lethal, but they are stigmatizing. And so transfusions can slow and potentially reverse bony changes, especially if they're started in children who are relatively young. And so in the United States, we would consider bony changes an indication for transfusions to avoid stigmatizing deformities. It's worth noting, however, that there are still the transfusion-related complications like bloodborne pathogens, which are still rare but still occur. transfusion reactions, or the development of red cell antibodies. And so even though we're really looking at trying to avoid some of the first three complications, we really have to be mindful about complications, and so would not transfuse without really a full disclosure to the families about potential risks. Iron chelation, I've mentioned, is the principal risk for transfusions. And so when we talk about using iron chelation, we want to be able to prevent accumulation of harmful levels of iron. We usually start iron chelation before iron accumulates to a degree which is likely to cause harm, and it also allows us to maintain iron balance before we get too far out of imbalance. We want to prevent tissue injury from iron itself, which can happen. And so we can do that and so chelation will allow us to achieve safe levels in tissues to make sure that it does not cause harm, and to potentially detoxify the effects of iron in some tissue. We know that iron chelation can reduce morbidity as well as mortality associated with iron overload. There are some toxicities associated with some of the chelators, and I will mention those on the next slide or two. But the current agents available really come in three different flavors. And this is actually a slide that summarizes these three different options. DFO is also called desferol, DFP is deferoprone, and DFX is deferocyrox or exnate or JADNU. They come in different dose ranges. They have different chelating capacities, with DFO or desferol having the greatest degree of binding, but the one that is probably most difficult for people to use because it has to be given sub-Q or IV. But the two oral agents come in different dosing ranges. They're excreted in different ways. They have different side effect profiles. They are all licensed in the United States, and it is well worth having a discussion with your local hematologist about how to orient yourself and how to think about the dosing and the monitoring that's needed for each one of the chelators. We need to monitor for iron overload, and the serum ferritin is widely available and is non-invasive, and so that's often the first test that we pick up. The problem is that it does not correlate as well as we would like to total iron burden, and so as a consequence, one needs to look at other ways to actually supplement the general the general impression you might get about iron loading using ferritin. And we believe in looking at the liver iron content. That is the best reflection of total body iron. There are a number of ways to do it. Liver biopsy used to be the standard of care, and I would say, really frankly, it is no longer. Something called SQUID is also very good, but yet it is the availability of that is quite low. Instead, most will use MRI, and a specific kind of MRI testing that allows you to quantify iron. And so it really does require, before you just send someone for a liver MRI, that you clarify that your institution has the ability to do post-processing, so after the images are done, to actually give you a numerical value for the liver iron content. Let's talk about what we might do, assuming that you have a diagnosis of thalassemia, you've needed to start transfusions, you've started chelation, but what else is out there to look at for the future of thalassemia? And the good news is that there's a number of different agents where we have some data, including the use of hydroxyurea, short-chain fatty acids, JAK2 inhibitors, activin receptor ligand traps, and I'll talk to you a little bit about that one because there's a commercial product out there. But other ways, if we could actually overcome the globin chain imbalance, that actually is a fundamental part of the reason for the anemia in thalassemia, or if we could institute iron restriction that would modulate ineffective erythropoiesis. There are a couple of drugs in the early pipeline that might do that. I mentioned there's an activin receptor ligand trap called luspatercept. In the interest of time, and because most of the people on this call are pediatric providers, this drug is not approved for children, and so, but yet in adults it's been associated with reducing the total amount of blood that people need to get on a routine basis for thalassemia. I want to talk a little bit about the endocrine complications because you do start seeing those early in pediatric life, and they include quite a few things. I've already alluded to growth failure, but others are delayed puberty or hypogonadism, hypothyroidism, diabetes, which again is largely occurs in adults. Same is true for hypoparathyroidism, and infertility and osteoporosis are also known complications of thalassemia itself. When we talk about growth failure, it can be from a number of factors related to thalassemia. Chronic anemia, say for instance in someone who is not being adequately transfused, in and of itself can cause growth failure. Iron overload in certain organs can cause central hypogonadism, and so therefore you're not growing because you're actually not getting things released from your pituitary gland. Chelation therapy, primarily desferal, was associated with short stature. Hypothyroidism, which I'll touch on in a slide or two, and growth hormone resistance, both of those can cause growth failure, as can zinc deficiency. It's important to make sure that you're getting an accurate height, which is a sitting and standing height, and the treatment really depends upon the etiology for growth failure. This slide that you're seeing right here, this figure in this slide, actually is someone who came to me with no transfusions as a teenager, even though she was really, really, really tiny. And so from age 14 to 16, actually 16, 17, I actually just simply started transfusing her. And look at the remarkable change with her crossing over several percentiles. This patient ultimately went on to cure at age 18 and is at this point one looking at this young lady would have no idea that she actually has thalassemia major. Delayed puberty usually occurs due to iron overload, and so assuming that one can begin chelation promptly early in childhood, this might be avoidable. The definitions of when do we actually call pubertal development delay is variable. It's slightly earlier for girls compared to boys, but it can result in primary amenorrhea. When I counsel my female patients who have thalassemia, I remind that they're at risk for secondary amenorrhea, that their window of opportunity to have children is going to be shorter than it is for someone who does not, because women with thalassemia are more likely to develop second amenorrhea due to primary ovarian failure due to iron overload, and it may happen in their 30s. And so just making them aware of that both of those are possible. And there are a number of tests that need to be done to monitor for that, and if necessary, being treated for hormone replacement. Hypothyroidism, I've already alluded to, is usually due to iron being deposited primarily in the thyroid gland itself, but it can also be central. The thyroid antibodies are negative. This is not an immune-mediated process, and we usually start seeing this after 10 years of age, and it does increase with age. And so the screening for that would be a T4 and a TSH. If you're really not convinced really is hypothyroidism, a TRA simulation test might be somewhat useful, but in most instances we simply pivot and begin hormone replacement with Synthroid. This summarizes the comprehensive care guidelines for patients with thalassemia, and you'll see it actually is a pretty remarkable list. And so many times this can be carried out by the primary care physician, but otherwise will be among the tests that are done at a comprehensive treatment center. I also want to call your attention to the banner at the bottom with the website. This is the website for the Cooley Anemia Foundation, and has these recommendations plus other guidelines on how to manage thalassemia. And so I encourage you to go there, but these are among the things that need to be done on an annual or in most cases or a monthly basis for thalassemia. Let's talk about curative therapies. It's certainly got everyone very excited, and the realities are that we've known for some time that bone marrow or hematopoietic stem cell transplantation has been curative for thalassemia for decades now. Most of that data comes from allogeneic matched related donor clinical trials. The matched donor, more often than not, is a sibling donor, and I'll show you some data about that one. Unrelated donors have also been done with success, and then haploidentical much less so in thalassemia, say, compared to sickle cell disease. I'm also going to touch on gene therapy, and I think it will be obvious when I get to that why. When we think about those who are fortunate enough to have a sibling who is a match, sibling donor stem cell transplants are now the standard of care. And why? It's because you would see improved chronic organ function as well as improved long-term survival. But it requires that you be done relatively young. So this is data showing less than 7 years of age with no evidence of hepatomegaly, which might reflect iron deposition, or hepatic dysfunction. As one gets to ages over 7 and with evidence of hepatomegaly, the risk of overall survival does go down somewhat. What is gene therapy? These are experimental techniques that uses genes to treat or prevent disease in its most simple form. But the one thing that's intriguing is that unlike allogeneic transplants, the patient serves as their own donor. And so for children whose families that have relatively few children, children who are adoptees, or children who unfortunately do not have a brother or sister who actually is an appropriate match, not required for gene therapy because the patient is their own donor. Gene therapy currently comes in 3 forms: gene addition, gene editing, and base editing, and I'm going to touch on all 3 in the remainder of this presentation. This is what the journey looks like. So patients who decide they want to have gene addition therapy come in and they have screening tests to make sure that their organ functions are good enough for them to proceed through a transplant. Those individuals then have their stem cells mobilized into circulation. So they're mobilized from the bone marrow space into circulation using 2 drugs, one called GCSF and the other called plerixafor. And then those cells are collected on an apheresis machine. They're sent to a centralized manufacturing facility where they are CD34 selected and then transduced to introduce the viral vector that has healthy, normalized hemoglobin, a beta globin gene to make hemoglobin, and then they're frozen. The patient, once their frozen cells are available, they're shipped back to my site, and the patient gets admitted to be given chemotherapy. Chemotherapy is an essential part of both transplants and gene therapy because we need to make space in the bone marrow for these normalized stem cells. After they've gotten 4 days of busulfan, they get 2 to 3 days of rest, and then their drug product, which is what it's called, is then reinfused. And then within weeks, we begin to see evidence of the effects of that because we hope to see recovery in the ability to make red blood cells, but now they'll actually be normal and more normal in appearance. But then also looking for evidence of the gene therapy vector output, and this is looking at something called hemoglobin AT87Q. Research studies have required 2 years of follow-up, but then also rolling over into long-term screening follow-up studies as well. And these are results from the gene addition gene therapy trial from Bluebird Bio that looks at patients, and each one of these lines is an individual patient experience. Starting with the red dots are the frequency of transfusions over the 12 months prior to coming in for gene therapy. And then the colored bars are really how are they faring after the infusion is given. At this point, what we can say is in the phase 3 trial, so the one that actually has led up to its approval, 90% of the patients achieved and maintained transfusion independence for a median follow-up of up to 6 years. And so kudos to all of my colleagues who have had these patients in their practice, irrespective of age. And so this is actually looking at children under the age of 12, between 12 and 18, and over 18 years of age. And in all cases, they're having excellent outcomes. I should mention also that 70% of the patients have achieved transfusion independence, and that's also another important assessment for us. Gene editing, you may have also heard about. It's very similar to gene addition in that the cells are removed from the body, sent to a laboratory where a manufacturing process goes on. But instead of introducing a globin gene, we actually do something called gene editing. And then those cells are reinfused, also following busulfan for chemotherapy. And this actually is a schema for the first use of CRISPR gene therapy in a human disease. And so this is using CRISPR-Cas9 to target a gene called BCL11A. BCL11A encodes a powerful modifier or transcription factor that allows, that when inactivated, could allow the reemergence of fetal hemoglobin, which is which may be a benefit in patients with thalassemia. And so the CRISPR-Cas targets the upstream or the enhancer region of the BCL11A gene. And then once that gene is actually again is actually inactivated, you'll then see the emergence of fetal hemoglobin, and that's what's shown on this slide. So similar setup with swimmer's plots, each line being a different patient, all the purple dots being the frequency of transfusions that they had in the 24 months prior to gene therapy. And then beyond that, going off to the right, are really the infrequency of new episodes or any new findings in these individuals. And so again, just really a remarkable set of experiments with 91% of evaluable patients achieving the primary endpoint of becoming transfusion independent with relatively high total hemoglobin. So hemoglobins of, mean total up to 13 grams per deciliter. There are 2 FDA-approved curative therapies, which I suspect some of you have heard about. One is called Exa-cel or Casgevy, and this one is produced by Vertex, and it again uses CRISPR-Cas9. It is only available to individuals over the age of 12, and you see what the price tag is. Another is one called Zynteglo or Beticel, and it's from a company called Bluebird Bio, and that's the one that I showed you that required the modification and the introduction of and production then of hemoglobin AT87Q. There are no age limits for thalassemia, although the youngest patient was 4 and the oldest patient was 37 at the time, but on the label there is no restriction for the time for thalassemia. And you'll note at the bottom the cost for Zynteglo or Beticel for thalassemia. So in summary, progress in thalassemia management has extended the lifespan for many, but the disease and some of the treatment-related complications, especially those related to iron, result in significant morbidity. Transfusions and chelation, when done properly, can be very effective, but they require close monitoring and consistent compliance by the patient and their family. Matched sibling donor stem cell transplants in families that are fortunate enough to have a matched sibling donor is now the standard of care. Gene therapy may provide, however, transformative therapy with durable benefits in transfusion-dependent beta thalassemia. I'd like to thank you for your attention, and I'm happy to answer questions.
Thank you, Dr. Thompson, for the truly great presentation. We'll now shift to the question and answer section of this webinar. Again, to submit a written question, please use the questions area in your toolbar. So we have the first question, Dr. Thompson, is for one of our participants. What is the genotype that results in beta thalassemia intermedia?
Well, there isn't just one. So literally, there are hundreds of mutations that cause thalassemias. And I wish I could tell you that a specific genotype always predicted whether you would be transfusion dependent or not, but it does not. There are other genetic modifiers, and I didn't go into those today, but there are hundreds of mutations that one might hope would allow the body to still produce some amount of hemoglobin A. I tell families to stay tuned. So even if they've inherited one of those, we monitor their children very closely over the first few years of life to decide whether or not their hemoglobin in fact stays up, whether or not their child continues to grow, whether there are any other concerns about bony deformities or anything else. And when I see those, no matter what your genotype is, we're going to recommend you be transfused. We recognize that that's a disappointment for some people who are hopeful that they've inherited the good kind of thalassemia. We just want to make sure that people are well with thalassemia, and so genotype matters. But I would say that more importantly, the question is does that individual need to be transfused? And if the answer is yes, irrespective of their genotype, that is certainly what we recommend.
And we have a related question that just came in. Does triplicated alpha globin mutations make beta thalassemia traits into an intermedia?
Great question. So that's one of those genetic modifiers I told you about. And the answer is maybe. And so when we think about thalassemia, so I mentioned that the beta thalassemias are caused by a beta globin abnormality, and the alpha thalassemia is caused by an alpha abnormality. But we require both alpha and beta together to make hemoglobin. And so if you're not making enough beta globin, you've got all these extra alphas out there, and those extra alphas actually damage the red cells and destroy them. When you have excess copies of alpha globin genes, which would happen in the case of triplication or in some cases quadruplication, that just makes that imbalance worse. And so someone may start out with what would look like an intermediate kind of beta globin mutation, but because they have a triplication of alpha, their imbalance is worse. And so that's a perfect example of someone who might, initially you might think that they have a more mild genotype, but in fact they don't. These are also examples of the reason why DNA testing is essential. I could not tell you any of this without DNA analysis. An electrophoresis or an HPLC will not tell me these things. And so while I concede that you'll have to jump through some hoops for most patients in terms of their insurance companies to get things approved, it's so important if you're going to manage a thalassemia patient, their genotype actually can be very helpful to be able to guide families about management.
Another question, can all thalassemia patients be picked up with newborn screening techniques?
Great question. You know, I think that, so I will tell you that I remain hopeful that every state in the United States will pick up thalassemia as newborns. And the reason why I'm hopeful for it is because all states in the United States pick up sickle cell as newborns. And whatever test most states use to detect sickle cell disease will pick up the most common, the most worrisome form of thalassemia, and that would be beta thalassemia major. And that's because the patient would only have hemoglobin F present at birth and not any hemoglobin A. And so in theory, you know, one would hope that you could pick it up no matter what test you were using. My recommendation is that all of us should be advocating with our states to actually add thalassemia to its newborn screening panel. It requires that we change the language in terms of how we interpret the results, including the recommendation perhaps that you be seen by a thalassemia specialist as early as possible to get DNA testing done to provide appropriate genetic counseling. But by and large, it is certainly possible that you will miss some forms of thalassemia with some of the screening tests that are used in a few states, but more importantly, making sure that it's being reported out by your state with giving you the appropriate recommendations that are general pediatrician on what to do next.
Another question, do you ever have alpha thalassemia minor patients who require treatment? What are the signs and symptoms do you look out for to determine if they require treatment?
So I don't really have patients with alpha thalassemia minor, if that's all they have, that require treatment. In fact, if someone has alpha thalassemia minor or are carriers and they're anemic, they should be referred to a hematologist. I think it's so important that they have a comprehensive evaluation to be sure that they don't, in fact, have some other condition. Because certainly there are other conditions beyond just that thalassemia that can cause transfusion dependence, and they're often seen in the same racial and ethnic groups that we see thalassemias. And so that alone should not cause someone to require transfusions. And so I would highly recommend that you get a consultation, whether it's an adult hematologist or a pediatric hematologist, because their chances are either that we're not interpreting tests correctly or that you've got something else.
So from one of our participants from across the pond in Greece, thank you. What is the lowest age that thalassemia can be diagnosed?
Birth. Fundamentally, it's birth. Yep. We certainly know that, and there is work being done, for instance, I didn't talk a lot about alpha thalassemia, for instance. Alpha thalassemia is so rare, but frankly, part of the reason why alpha thalassemia is rare is because many babies die before they're born. And so when a family has had a baby who's died before birth, they should be worked up, especially if they are a family that believes that they're at risk for thalassemia. When we see that, those babies can survive if they start if they're diagnosed before they're born, and if they're transfused in utero or before they're born. We also have the opportunity to use something called pre-implantation genetic diagnosis. And so if a family knows that they're at risk, we strongly recommend that they see a genetic counselor, that they see a reproductive endocrinologist, that they see a hematologist to get good advice about whether or not they want to proceed with a pregnancy that could be at risk for having a child with thalassemia. But if I'm talking about children who come to full term, they could be diagnosed at birth.
Let's see, the next question is iron deficiency anemia associated with thalassemia trait?
They're often confused with thalassemia trait. so I wouldn't say associated with it. But yet, you know, I do think that that it's very important if you have a child, or even that for that matter, a teen or an adult who has a microcytic anemia, it's worth keeping thalassemia trait or thalassemia minor on your radar. But iron deficiency is certainly much more common. My recommendation in the setting of most patients is to actually get a set of iron studies, to look at a serum ferritin. If I'm going to do one test, that's probably the test that I do, or to get an iron panel. By and large, if someone has iron deficiency, by all means treat it. Now, after you've treated the iron deficiency, if their MCV is still low, then you probably want to think about doing the DNA test that would actually identify someone's abnormality with the alpha globin. But by and large, I find that most of my patients with a microcytic anemia, it's just that they have iron deficiency, and when I fix their iron deficiency, their MCV goes up. But certainly, I would absolutely go down that path if after treating the iron deficiency, they're not better. And there is no increased risk of iron deficiency with alpha thalassemia. Just a really common condition, though, among humans.
Let's move on to some of the questions regarding treatment. So is there a role for hydroxyurea?
You know, we've tried and tried and tried. Yes and no. There definitely are some people who still treat people with NTDT or non-transfusion dependent thalassemia with hydroxyurea. The primary data is that it may cause some shrinkage of organs because people with thalassemia do have organ enlargement. It may also control the size of something called extramedullary hematopoiesis, which are these outpouching of the marrow space that can cause real serious symptoms when they occur in bones or they impinge upon nerves. And so there's a little bit of data to suggest that hydroxyurea will help with that. I find that what will also help with those individuals is to start them on transfusions. And at that point, it gets a little bit hairy. I'd have to say that if I really thought before I would put someone on hydroxyurea, I would refer them to a hematologist because I do think that there are ways to tackle thalassemia more directly than hydroxyurea today.
So I have a question from one of our colleagues. When we counsel sickle cell disease patients in terms of life expectancy with supportive management only, it is much easier to make a case for curative therapy. What is your estimate of the life expectancy for children with transfusion-dependent thalassemia, transfusions, and iron chelation? How would you frame this versus allotransplant or gene therapy?
Yes, great question. And I think about it somewhat differently. So I concede that we have been successful with increasing the lifespan in thalassemia with transfusions and iron chelation. It's worth noting, however, that people who have, so they may live a lifespan that is fairly long and is not that much shorter than one would see for people who don't have thalassemia. The complications of thalassemia only continue to accumulate. These will be individuals that will only have more of those complications as they get older. They're going to have arthritis a lot earlier. Women are going to have issues with osteoporosis much earlier. They will have premature menopause if they have thalassemia. So none of these things are great. So they might survive, but this is survival, though, with some major complications. They can have diabetes, as I've already alluded to, and other endocrine disorders. And so trying to actually head off those kinds of morbidity, in my opinion, is compelling. The other part of that is if I looked at if this patient had a sibling donor, I wouldn't hesitate to transplant them because I can only offer you a lifetime of transfusions. And that requires that you be always tethered to the healthcare system. So your ability to travel, your ability to really have the freedom to decide what you want to do are limited if you have thalassemia no matter what. I think also there have been a number of cost, benefit, and risk considerations done. And suffice it to say, with all the screening tests that had to be done over a lifetime of transfusions and chelation, that the cost of gene therapy even today justifies actually proceeding with gene therapy. When I look at the overall cost over a lifetime, especially if the gene therapy occurs in a child. And I will tell you, as a center that does gene therapy, we've been doing them since they were FDA approved in 2023, and we don't have rejections by and large. That by and large, we make the case with insurance companies that it is worthwhile from a financial perspective and from a perspective of morbidity to proceed with gene therapy.
So I think you answered several other questions that were very similar to this about how patients are paying for these multi-million-dollar procedures. So I think we'll move on to other questions. This is kind of going back to diagnosis. Can you review the typical hemoglobin electrophoresis for a thalassemia minor versus a thalassemia major?
Yeah, they're very different. So a thalassemia major, the classic thalassemia major is really only seeing hemoglobin F. And that would be because that individual does not make any beta globin and therefore cannot make adult hemoglobin A. And so the predominant hemoglobin at birth is F, but there's no A, not even a little bit of A around. And so that F only should definitely trigger a referral for a probable beta thalassemia major. It's also possible for someone to have, but in the case of someone who, say, has trait, they have FA is what their newborn screening result. And I would consider the vast majority of people who have FA are normal, that they don't have thalassemia at all. If you have a family history of thalassemia, you might want to let people know, because at some point in the first 6 months of life, someone should do a complete blood count. And if you're a microcytic, should show the prompt some more testing done. And again, that's going to be DNA-based testing. But by and large, trait and disease should sort themselves out pretty quickly. But certainly if F only, again, be worried about thalassemia. FE, again, we're seeing increased numbers. And in fact, the most common form of transfusion-dependent thalassemia now in the United States is actually E thalassemia. They have FE, but again, they don't have any hemoglobin A, that normal healthy A. That patient has hemoglobin E beta thalassemia until proven otherwise. And so again, really requires additional testing done, often DNA or molecular testing, to be sure that we're giving patients accurate information about what their risks are.
I think you've probably answered this question already. If one sibling has thalassemia, can the second sibling get it as well?
Yeah, you know, I must tell you, that's the unfortunate part about genetics, isn't it? You know,
Yeah.
you still think that if you have one pregnancy, you roll the dice and you're normal, then you're good to go all the time, even though you are a carrier. Same thing is true if your first child is affected. The frequency of the gene is the same through every pregnancy as long as the parents are the same two parents. And so even though there's a 1 in 4 chance with two parents who are affected, who are carriers, that is true for every pregnancy. So you may have a first child with thalassemia, but just know you could have a second child with thalassemia and a third child with thalassemia. So important to make sure that you're getting and providing accurate advice to families, many of whom are hopeful that it won't happen again, that they will be lucky enough. We just have ways to give people better information than that. But thanks for asking that one. Some people don't quite get that one right, but it's really important that that risk is for every single pregnancy.
This is a good question. Is hemoglobin A2 testing plus the CBC good enough for diagnosing thalassemia, or do we really need DNA testing?
Yeah, so great question. I don't find that A2 alone gives me nearly as much. It gives me clues. If I have someone who has a microcytic anemia, and they have an elevated A2, yeah, I probably would refer that patient to a hematologist. If I have someone who has sickle cell disease and has an elevated A2, they could have sickle beta thalassemia. Now, bear in mind, that is not a form of thalassemia. That's a form of sickle cell disease. But again, I'd refer them to a hematologist too. A2 is kind of tricky. I wouldn't otherwise put too much weight on it, especially if someone is not anemic and their cells are not microcytic. In fact, you wouldn't otherwise see an A2 quantitation typically being done unless there was some other reason to suspect that you're going to find something.
I think we have time for just a handful more questions. There is good evidence for protection from malaria for those patients with hemoglobin S. Does this protection also hold true for those with thalassemia?
Great question. Not nearly as much as one would think, but because really the challenge there is that many people who have the most severe forms of thalassemia become evident very quickly in life. And bear in mind, that protection really is about being a carrier or having trait. So both in the case of both thalassemia and sickle cell, children with sickle cell disease who contract malaria are more likely to die from malaria. The presence of sickle hemoglobin inside a red cell for someone who has trait means that that red cell is more hostile to the malaria parasite, so it's less likely to reproduce itself inside the red cells and therefore may be protective. By and large, I think we're very fortunate in that, you know, when we, for those who live outside of malaria endemic areas, that usually isn't something to be concerned about. But it certainly does explain why these traits have persisted across centuries in human beings, because there had been at least a protective advantage or survival advantage for carriers. But I would say that either way, we want to avoid people having malaria. We want to diagnose people with thalassemia the right way before they would ever be exposed to malaria.
There was a comment and not a question, but I think it probably could lead to some commentary by you, Dr. Thompson. There is no access to gene therapy or transplants in places like Ghana.
Yeah, I couldn't agree with you wholeheartedly. I think that what we're looking at is two things. One is the opportunity to see more children survive. So, for instance, the statistic that I think strikes me as so profound is not about thalassemia, it's about sickle cell. In the United States, children with sickle cell are diagnosed by newborn screening, and 98% of them will live to adulthood. In Africa, including places like Ghana, 90% of them will die before adulthood, and many of them will die before their 5th birthday. So for me, a diagnosis and interventions with penicillin vaccinations and malaria prevention are going to save lives while we're looking for ways to actually extend access to gene therapy and stem cell transplant globally. There is work being done in safer and cheaper allogeneic stem cell transplants and also cheaper, ideally simpler forms of gene therapy, like things that are called in vivo gene therapy. We're not offering that anywhere. It's not available. It's not even in clinical trials anywhere. I would say stay tuned. I think that it is coming, and a lot of the effort in vivo gene therapy is with the idea in mind that we must be able to be more equitable in having people having access to things like curative therapies. But I couldn't agree with you wholeheartedly that today's methods of gene therapy are out of reach.
So it looks like that we've run out of time. We would like to thank each of you for joining us today, and we were sorry that we couldn't get to everyone's questions. We appreciate the invitation from our colleagues at the CDC's Division of Blood Disorders and Public Health Genomics to present today on thalassemia. And we'd also like to thank our colleagues at the Cooley's Anemia Foundation for hosting today's webinar. Very shortly, you will receive an email asking for your feedback, so please respond with your comments. If you have any additional questions about today's presentation or suggestions for additional topics that you would like to hear about, please email at dpdhgevents@cdc.gov. Today's webinar will be archived, and the content will soon be available at the CDC's Division of Blood Disorders and Public Health Genomics website as shown on the slide. Thank you for joining us today, and have a great afternoon.